Hello everyone, this is Dr. Tania. I'm a high-risk pregnancy consultant. Today I'll be talking about the management of hyperthyroidism in pregnancy. So in our daily practice, we see so many cases of hypothyroidism in pregnancy, but hardly any case of hyperthyroidism because this is very uncommon. Only 0.1 to 0.4% of pregnancies will be affected by hyperthyroidism. So, what is the actual cause of hyperthyroidism in pregnancy? So in 75 to 85% of cases, hyperthyroidism in pregnancy is because of Graves' disease. We all know that Graves' disease is an autoimmune condition. It produces antibodies against the thyroid receptors, and that will stimulate the thyroid receptors, produce more thyroid hormones, and that was the levels of T3 and T4, they are much increased in the blood. So this is all about Graves' disease. So what is important about Graves' disease is that these antibodies, they are thyrotropin receptor antibodies, that is TRAbs. They cross the placenta because they are IgG antibodies. So they are very important. So let us see what is their importance. So coming directly to the management, any patient who comes to us, we always go for TSH. TSH is checked, and as we know that the levels of TSH in the first trimester, they are much reduced because of the high levels of HCG. So whenever you see that the TSH levels are even below the normal range, we go for free T4 to confirm that yes, this is overt hyperthyroidism and this is not something, physiological changes of pregnancy. These two tests, when they are done and we have made the diagnosis that yes, patient is suffering from hyperthyroidism, after that the third and a very important step is the measurement of these TSH receptor antibodies, that is TRAbs. Now, why TRAbs are important? See, these are, as I told, these are IgG antibodies. They can cross the placenta. They can cause fetal hyperthyroidism. Now, one very important point I would like to highlight here is that if any patient who is already having Graves' disease, or earlier TRAbs were there in her blood, like they were increased in the blood, or the previous pregnancy, the neonate was suffering from Graves' disease, even if thyroidectomy has been done for the patient, or patient has taken the ablative therapy earlier, in all these cases, please look for TSH receptor antibodies. Because even if thyroidectomy has been done or radioactive ablation has been taken, TRAbs may persist. And thinking that thyroidectomy has been done and that ablative therapy has been taken, if we will not check, these TRAbs might cross the placenta in pregnancy, and they will cause fetal hyperthyroidism, and we will not even come to know. So please look for thyrotropin receptor antibodies whenever you encounter a case of hyperthyroidism in pregnancy. So how will you treat these cases? So as far as the treatment is concerned, the anti-thyroid drugs, they are thiamides, that is PTU, propylthiouracil, and methimazole or carbimazole. Two main drugs, PTU and methimazole, we generally treat hyperthyroidism with. So what is the strategy, how you have to start the dosage? You have to start the dosage, like you have to start the lowest possible dose, that is one. Second important point is your aim should be to maintain the TSH slightly lower than the lower limit of a normal range. The normal range, the lower limit of normal range, TSH should be slightly lower than that. Free T4 should be on the upper limit of normal. If you maintain this strategy, so with this, it will not cause fetal hypothyroidism. Otherwise, PTU and methimazole both cross the placenta, and they freely cross the placenta, and they might go to the fetus and cause hypothyroidism there. So these 3 points are very important. You have to go according to that.